Hi guys, so this short talk will just take you through the four types of hypersensitivity reactions that you're likely to encounter in clinical practice, but also in your Part 1 exam. So the first case is a 32-year-old female patient who presents to the emergency department with an itchy rash, which started 2 hours after eating shellfish. Her vital signs are stable and her chest is clear. So I just want you to pause the video, think about what this is, what type of hypersensitivity reaction, the mechanism of the hypersensitivity, and how you might treat it and how the drugs you use might work. There are 4 types of hypersensitivity reactions, types 1 to 4, ranging from acute allergic reactions mediated by IgE antibodies through cytotoxic reactions, immune complexes, and then delayed or cellular hypersensitivity. Of course, this first case is type 1 hypersensitivity, which is defined as an immediate reaction to an antigen and involves an IgE-mediated release of antibodies against soluble antigen, which results in mast cell degranulation and the release of histamine and other inflammatory mediators. There are 2 recognized phases: the sensitization phase, which is the first exposure to the allergen, in which the allergen is intercepted by antigen-presenting cells such as dendritic cells or macrophages, then presented to T cells within the lymphatic system, which then primes B cells to produce IgE antibodies. These B cells are then stored in the lymphatic system, and the T cells can signal them on a second exposure, which is the antigen activation phase. These IgE antibodies bind Fc receptors on mast cells and basophils and cause release of a variety of inflammatory factors. Yes, histamine is one, but it might not even be the most important one. Histamine, bradykinin, serotonin-like substances, interleukins 1 and 6, tumor necrosis factor, and various cytokines, all of which produce the typical Whelan-Flare reaction, and in anaphylaxis, more severe reactions such as bronchospasm, hypotension, tachycardia, and airway obstruction. So what are the drugs that we can use? Well, epinephrine is really reserved for the anaphylactic type reaction, and it causes alpha-1, alpha-2, and beta-2 agonist effects leading to cardiac stimulation, vasoconstriction, bronchodilation, and mast cell stabilization. Steroids typically stabilize the mast cell and reduce the release of inflammatory factors, decreasing biphasic and delayed reactions, whereas the H1 and H2 antagonists block histamine receptors and reduce the effects of histamine, causing reduced capillary permeability, reduced edema, and reduced itching. Here's a second case: a 23-year-old male patient presenting after suffering a severe postpartum hemorrhage. I presume that should be female patient, I apologize. 4 weeks ago. She was transfused 6 units of packed red blood cells. She admits to having had a reaction to the transfusion with fever, muscle aches, arthralgias, and skin rash, and she now complains of shortness of breath on exertion and appears pale and mildly jaundiced. So again, pause the video, see if you can work out what's going on here. This is a type 2 hypersensitivity reaction. It's antibody-mediated IgG or IgM directed against cellular or extracellular matrix antigens, and some examples include transfusion reactions, drug hypersensitivities, hemolytic anemia, thrombocytopenia, and the others that are listed. There are 3 mechanisms of injury: antibody binding to surface receptors, which changes the activity of cells; activation of complement pathway, which causes destruction of tissues; and antibody-dependent cellular cytotoxicity. And these pathways can lead to either cell destruction without inflammation, or inflammation mediated by complement, or cell dysfunction due to the effect of the antibodies. Of course, if we want to treat, we remove the inciting trigger and provide appropriate immunosuppressive therapy, which could be drugs or other immune modulation such as plasma exchange, IVIG, or thymectomy. Here's a 6-year-old child with swelling of the face and feet. He'd been getting multiple mosquito bites over the past few months, which have got infected from time to time. On examination, the patient is hypertensive and his urine shows microscopic hematuria and red blood cell counts. Again, pause the video and see if you can work this one out. Yep, so this is type 3 hypersensitivity, which is due to the formation of antigen-antibody aggregates or immune complexes, which then precipitate in skin, joints, vessels, or glomeruli. And it can be seen in things like serum sickness, hypersensitivity, pneumonitis, or acute glomerulonephritis, particularly post-streptococcal. Etiological agents can be things like antivenoms, other medications, certain infections, particularly group A beta hemolytic strep, but also hepatitis and some of the organisms causing endocarditis, and autoimmune disease such as SLE. The actual process involves 3 steps. First, immune complex formation, then the deposition of these complexes in the tissues, and finally localized inflammatory reactions around the deposited complexes in the tissues described above. Of course, the treatment would be to remove the inciting trigger and, where necessary, provide appropriate immunosuppressive therapy. Finally, a 54-year-old male patient who presents to the emergency department with increasing shortness of breath for 6 months. His X-ray shows multiple enlarged hilar lymph nodes with reticulonodular opacities, and a lung biopsy shows non-caseating granulomata in the lung parenchyma. Again, pause the video and see if you can work out what's going on here. This is typical of sarcoidosis, which is a T-cell hypersensitivity or type 4 hypersensitivity. And this is really a hypersensitivity mediated by the activation of T cells, which in turn can provoke an inflammatory reaction against antigens, either exogenous or endogenous. Other cells may be involved, but they are triggered by the T cells. And common types of type 4 hypersensitivity include contact dermatitis, Stevens-Johnson syndrome, and toxic epidermal necrolysis, tuberculosis, sarcoidosis, systemic fungal infections, and drug hypersensitivity. There are distinct mechanisms in different types of type 4 sensitivity. So type A is macrophage mediated, whereas type B is eosinophil mediated, and type C is cytotoxic. And each of these produces a slightly different clinical picture. So toxic epidermal necrolysis, for example, tends to be cytotoxic in nature, and that's why the tissues are damaged, whereas the granulomatous diseases tend to be more macrophage mediated. These conditions can cause multi-organ involvement of the skin, lungs, kidneys, joints, bones, and soft tissues, and may lead to chronic inflammation with fibrosis and scarring, or severe cytotoxic tissue injury such as in Stevens-Johnson syndrome or toxic epidermal necrolysis. If you have any questions, you can bring them up in class. We've talked our way through the 4 types of immunological hypersensitivity reactions. This is just to form the basis of an understanding of the conditions. You do need to read more for your Part 1 exam. I hope this was useful. Thank you.